For today's webinar, we have Kelly Keys from RTI International presenting Death Certification by the Medical Examiner Coroner in Drug-Related Deaths. Without further delay, here's Kelly.
Good day, everyone, and thanks for joining us to learn about death certification by the Medical Examiner and Coroner in drug-related deaths. I'm Kelly Keys, a board-certified medical legal death investigator with over 24 years experience working in a large sheriff coroner's office in California. I spent much of my career as a supervising investigator, performing and overseeing over 10,000 death investigations and certifying thousands of death certificates over my career. Through my 24 years, I've had the opportunity to be involved in a lot of projects related to death investigation with other jurisdictions, including on drug death investigation and certification, and also opportunities to work with death investigation personnel from all over the country through OSAC and IACMA, amongst other groups. I recently retired and transitioned over to a position as a research forensic scientist at RTI International. Standard disclaimer, these thoughts are mine alone, and none of our federal partners are responsible for what I say here. There's a lot of variance from state to state and jurisdiction to jurisdiction, but I'm going to try to capture the basics. I'm sure many of you will think, well, we do it a bit differently here, but maybe see how you can apply some of these principles within your state or within your jurisdiction. Hopefully there is something today for everyone, no matter if you are an aspiring death investigator or a forensic pathologist with years of experience. I want you to learn about how the information on a death certificate is used, especially for public health purposes. We will talk about how to complete the cause of death information on a death certificate, especially as related to drug-related deaths. And lastly, we will cover how to complete the injury information on a death certificate. With everything I talk about, I really want to make sure that we keep in mind the public health responsibilities associated with medical legal death investigation. Because I've said for years that my goal is to put myself out of a job. Wouldn't it be just such a wonderful world? I know that everyone in the industry is overloaded with work right now. So wouldn't a world with no overdose deaths be great? Imagine how much less stressful this job would be. So I encourage certifiers and offices to be consistent in how they choose to complete death certificates, but don't get complacent and not allow that consistency to prohibit evolution within an office or within your practices. I'm going to start with some basics since we have a varied audience, and I want to make sure that we're all on the same page. With that, we will briefly talk about what is a death certificate. Then we will discuss the role of medical legal death investigation to public health and public safety. Of note, throughout the presentation, I will use the term MDI to cover the vast scope of people, from coroners, medical examiners, forensic pathologists, death investigators, justices of the peace, and anyone who conducts an investigation to determine the cause and or manner of death. We will talk about the problems in recent years and how to improve what we're seeing as far as death certification, especially with drug-related deaths. I will briefly cover the importance of the investigation and scene findings as related to completion of the death certificate, and the importance of autopsy, toxicology, and potentially other ancillary testing to the process. Then we will talk about how to best capture the cause of death on the death certificate itself, including understanding the nuances between parts 1 and 2 of the death certificate. Then how to deal with the ever-increasing deaths with multiple drugs. We will then briefly talk about deaths where the cause is a complication of acute intoxication. And a note here that as I am not a forensic pathologist, I'm not going to be talking about determining causes of death, just things to be aware of through the process. And we will then talk about manner of death and the importance of completing pending death certificates. We will close with some discussion of completing the very important injury section of the death certificate. And lastly, I hope to provide you with a few additional resources for you to reference down the road. A death certificate is a legal record of death issued by the government. The World Health Organization produces guidance about an international standard format for the death certificate, and that informs development of the U.S. standard death certificate, which states in turn use to create the death certificates for their jurisdictions. Hence, as you will see, as I show a couple examples, there are many similarities between these state certificates, but there is some variance, such as on questions about tobacco usage and pregnancy, as well as formatting. A death certificate captures demographics about a decedent, such as occupation, address, and education, as well as captures information specifically about the death, such as when and where the death occurred, the cause and manner of death, and for unnatural deaths, information about the incident that caused the death. These later parts, from cause and manner of death on, are considered to be the medical portion of a death certificate and are to be completed by a physician or a medical examiner or coroner. The demographics are generally provided by the family to the mortuary who in turn lists it on the death certificate. Once both parts are completed, the death certificate is then filed with the registrar, who is usually part of the health department, and they in turn issue certified copies to interested and eligible parties. Over the last 10 years or so, most states and jurisdictions have evolved to completing death certificates completely online via EDRS, that's the electronic death registration system, with an attestation taking the place of signing a death certificate. I will, though, continue to use the terminology of signing a death certificate throughout my presentation. The other thing I want to cover about death certificates is who can sign them, recognizing this can be a hot button issue for some. This varies from state to state and from jurisdiction to jurisdiction, but for deaths falling within the medical examiner or coroner jurisdiction and not ultimately referred back to a treating physician to sign the death certificate, it can usually only be signed by the medical examiner, the coroner, or a deputy of those positions. This does mean in some jurisdictions, death certificates can be signed by a non-physician. This does not, however, necessarily mean that the cause of death is determined by that person. Coming from a coroner system, I signed thousands of death certificates in my career, but not being a physician, I did not determine the cause of death for those cases. We had an amazing team of forensic pathologists who determined the cause of death on each of those cases. I, however, was responsible for ensuring the medical opinion of the forensic pathologist got onto the death certificate and that the investigations were complete and that the manner of death was accurate, consulting with the forensic pathologists as needed. The role of a death certificate has evolved. It was initially developed as a way to document a death and provide a legal way to prove that a death occurred for purposes such as life insurance, financial institutions, and other entities for settling an estate. It has evolved to also be used for statistical purposes, with the information being transmitted from the local registrar to the state health department to the National Center for Health Statistics, NCHS, and that's one of the centers at the Center for Disease Control at CDC. There, the information is analyzed to determine the health of our nation. The information the death certificate provides to CDC is also used by researchers once it is analyzed at NCHS. The basic process of how it is analyzed at NCHS is by using ICD-10 codes. That stands for the International Classification of Disease Codes. These are codes assigned by the World Health Organization to different diseases. So each condition on the death certificate is assigned a corresponding code. A death due to asthma would be assigned a J45 code, and a death due to hypertensive heart disease, an I11 code. You don't need to know those codes, but they are what happens at NCHS. And then once each condition listed on the death certificate is assigned a corresponding code, those codes can be statistically analyzed. There has long been an association between the information collected in death investigation and public health. Some examples include the evolution of car seat laws and the Back to Sleep campaign. More recently, we have seen practices about Narcan distribution develop out of data identified from analyzing death records. I think we would all admit that cars and workplaces are safer because people reacted to problems that they saw in the past, often as a result of fatalities or severe injuries that in turn informed better practices and safety measures. Yet despite all the progress made over the years, many in the MDI world fail to recognize just how big of an impact they can have. A medical legal death investigation has a goldmine of data that your health department probably are interested in because you know the biggest challenges in your community. You know that a lot of Dr. Jones's patients seem to die of overdoses on their prescription medications, or that all of a sudden there's been a surge of cocaine in your community. If you don't already have good working relationships with your health department, give them a call and see if you can establish a relationship. If nothing else, they usually have access to a lot of grant funding and can possibly work with you to share some of that funding and resources with you. This is something I really want everyone to take away today, and I will mention it throughout. I encourage you, when you are making decisions in your office over the next few weeks and months, to think of the role you can play to prevent deaths and how you can share the information you have, either directly through those relationships with your health department, or even by making better use of the death certificate to share that information. If the you of the past didn't share that children were getting caught and dying in the cords of blinds, we wouldn't have safer blind courts today. So a thorough and valuable death certificate really begins at the time a death is reported to the Medical Legal Death Investigation Authority. The goal is to get cause and manner of death information as accurate as possible in these cases. Well, if a case is not thoroughly investigated, then it is much more likely that an overdose death will be missed. If you aren't looking for it, you aren't going to see it. This would apply to checking the decedent system for toxicology. If toxicology testing isn't performed, you certainly will not find that it's an overdose. It's kind of like saying that you don't have any cavities in your teeth, but then admitting you haven't been to the dentist since 1999. You may have cavities, but you just don't know about it because you haven't had the experts look. So in my former jurisdiction, we didn't have any fentanyl overdose deaths recorded before I think it was 2015, but that might have been because we really weren't looking for it. Might it have also been because they didn't exist? Sure, but we really don't know because we weren't looking for it. It wasn't a known thing at that time. Now, certainly I'm not inferring that toxicology needs to be done in all cases, but given that more and more overdoses are being seen in the elderly and in decedents with pre-existing health conditions, it's important to thoroughly evaluate all cases and not just jump to the conclusion that an elderly person died of natural causes. I'll admit that 20-something years ago when I started this career, there was a lot more assumption made in certain cases. But as the opioid epidemic grew and more people were overdosing on more than just street drugs, my index of suspicion increased across the board for all cases. And autopsies were ordered on cases that might not have been done in years past, and overdoses were found that might not have been found in years past. Also, early identification of these cases allows for the medical legal death investigator to respond to the scene. Once it's seen, not only can they be on the lookout for clues to possible overdose, such as the cone of foam or positioning indicating the decedent nodded off or died in the middle of something else, it also allows for the collection and or documentation of evidence that can be useful later in the investigation. This includes clues that a full autopsy is warranted rather than just toxicology, clues that suggest to the pathologist that toxicology should be ordered to put their findings in context, clues to suggest medication history of the decedent that can add context to the toxicology finding, and clues to routes of administration and possibly even where certain substances were obtained. Collecting evidence at scene that includes residue or remaining drug material can even lead to helping specify what drugs are in a decedent's system, especially when nothing is found on the basic tests and more advanced toxicology is needed. Having the materials can inform what to test for. So let's talk about a bit more about the importance of autopsy. If the death certificate starts with the scene, what about the autopsy? That's an equally important step along the way to accurate death certification. I know there are many agencies that do not have the resources to do as many autopsies as they would like, and some overdoses sadly don't get autopsied. If that's your jurisdiction, I understand you're probably doing the best you can and probably fight this fight every day, and applaud you for doing what you can. But a complete autopsy is so important to fully understanding drug-related deaths. They provide a context to the toxicology findings that would not otherwise be obtained. This could include documenting certain findings related to the toxicology, such as certain conditions in the heart or brain, like a hypertensive bleed, or multiple pills in the stomach that could provide concerns for suicide, or even trauma on the rare drug-facilitated homicide. If toxicology comes back at low or therapeutic levels of drugs or medications, the findings of the autopsy can provide a context that this was actually a natural death with incidental toxicology findings. There are many resources out there talking about how important it is to do autopsies on these cases, such as the National Association of Medical Examiners paper on this topic. And I encourage you to read these resources and use them to try to get what you need in your jurisdiction. Because there have been many occasions that what seemed like it should be an overdose, well, after tox came back, it wasn't. And the autopsy allowed us to get the death certificate correct and to provide truthful answers to the family and to society. It's hopefully obvious that toxicology is important to certification in these cases as well. But the key is to ensure that the correct tests are run. It's helpful to know what new and emerging substances are in your area so you can be sure that you are testing for those. Some of the basic drug tests only look for the basic drugs, and I think we all know that overdose cases are not basic like they once were. It's also important to not just do screening tests, but to also have levels of drugs run, especially for prescription drugs, even when diverted. There are safe levels of these drugs that can vary from person to person depending on potential tolerance, and these levels provide a framework to interpreting the toxicology in combination with the autopsy findings and any other findings. I also want to mention ancillary testing. Some of the more common ones include histology performed by the forensic pathologist, microbiology, other lab studies, and even genetic studies. Again, all tests that can give context to the totality of the death investigation and other findings. Now let's talk about how to complete a death certificate in general. In the medical section of the death certificate, Part 1 should be completed with a causal sequence of events that directly lead to the death. There are 4 lines available in this section, although not all 4 lines need to be used in many cases, and in some cases, just one will suffice. The top line is the immediate cause of death, with the subsequent lower line being the disease or condition that caused the line above it. So for a natural death, some examples of a causal sequence would be acute myocardial infarction on line A, which is due to atherosclerotic cardiovascular disease on line B. Or another example, line A here lists pneumonia, with line B being cerebrovascular accident, with line C listing hypertension. That's a direct causal sequence. A is due to B is due to C. An example of something that is not a good causal sequence would be aspiration pneumonia on line A, with chronic kidney disease line B, Alzheimer's disease on line C, and then chronic obstructive pulmonary disease on line D. These all might well be an important part of a decedent's medical history, but they're not a causal sequence to explain the death. Aspiration pneumonia is not due to chronic kidney disease, which is not due to Alzheimer's, and so on. So this is where Part 2 of the death certificate comes into play. This section is for other significant conditions that contributed to the death but did not result in the underlying causes listed in Part 1. So for this last example, a better way to sign that death certificate would be listing line A as aspiration pneumonia and line B as the direct reason for that, or in this case, the Alzheimer's dementia. And then Part 2, which I've highlighted here, would be where the chronic kidney disease and the COPD could be listed, as they're important factors to the patient's history, but did not directly lead to the sequence of death. While a medical examiner or coroner's office primarily does investigate natural deaths and signs the majority of cases out as deaths due to natural disease, there are a number of cases that are not natural, certainly. The same rules really do apply. For unnatural deaths, some examples of a causal sequence might be exsanguination due to multiple self-inflicted stab wounds of the chest, neck, and left arm, or a subdural hematoma due to blunt head trauma due to a fall. For this first example, you might want to include something on Part 2 of the death certificate about their chronic depression. And in this second example, you might want to include that they were on anticoagulation therapy for atrial fibrillation, as it's important to the totality of understanding the cause of death, but not directly in the sequence. Also, you'll notice for both of these examples, I went ahead and completed the time interval fields. This is a requirement in many states and becoming required in more and more. When available, please complete it. If you truly don't know, you can always use unknown, but it's best to complete it, and you can see that it's hours, days, days. So it leads to that causal sequence. It supports that causal sequence. So remember these 2 examples, as we're going to refer to them on the next page as well. If a death is not due to natural causes, there are some additional fields that need to be complete. These include the injury information. This includes date and time of the incident, incident location, and a description of what happened, plus the manner of death. For the manner of death, especially for homicide, I just want to note that this is not a legal conclusion, but rather a designation specifically for the death certificate. And we'll talk a little bit more about that in a bit. So for that first example, our decedent with the self-inflicted stab wounds, the location would be where she injured herself, perhaps at her home. And the date and time of the incident would be as close to the known incident time as possible. In this case, I went ahead and added an estimated along with it. Many jurisdictions allow for that. For the incident information, you would want to provide a brief summary of the incident, such as, in this case, self-inflicted stab wounds with kitchen knife. And then barring nothing unusual, the manner in this case would be suicide. For the second example, you would list where he fell in the decedent's residence front yard. And for the injury description, you would list something like fall off ladder while putting up Christmas decorations onto the driveway. This manner would likely be accidental. For injury information, you also have to complete the injury at work section. And unless the second decedent was a professional light installer, you would mark no for both of these. Let's talk about the medical parts of the death certificate specifically now as it relates to overdose deaths. We will start with examples of overdose cases with simple toxicology findings and get gradually more convoluted. An example of how a death certificate might read for the simplest overdose case might be acute cocaine toxicity or acute cocaine intoxication on line A, where this is either the only thing found in toxicology or the only substance that the death is being attributed to. Findings like THC or caffeine or low levels of hydrocodone would likely not be listed as part of this cause of death, as their effects did not directly contribute to the death. Additionally, a finding like benzoyl would not be listed as it's a byproduct of cocaine, not a substance the decedent took, plus it is not pharmacologically active. It's important to be clear that it was the toxicity of the drugs that led to the death, and avoid listing terms like used as part of the cause of death. So you wouldn't want to say used cocaine, or even less specific, used drugs. Terms like abuse and addiction are generally inappropriate on the death certificate as part of the cause, at least for drug-related deaths, since they don't describe an acute event causing the death. The exception to this could be complications of chronic abuse, and I'll cover that in a little bit. A slightly more complicated example might have the cause of death as clonazepam, diazepam, and lorazepam toxicity on line A. Because these are all things that are found in toxicology tests and are all considered to be substances that are pharmacologically active and or have synergistic effects with one another, they all would be listed. In this case, I've listed those all in alphabetical order rather than trying to list them in order of, say, importance. You can list them in any order you want. The key is to be consistent in how you choose to do so, and alphabetical is always easiest to explain. Again, in this example, if there was a low level of diphenhydramine and a very low level of alcohol, perhaps the latter even being from decomposition, the forensic pathologist will likely opt to not list those unless she feels they're relevant to this particular death for some reason. And then also, I just want to note that I am referencing all of these drugs by their chemical name, not the brand names, and that's how it should be listed. An option for part 2 on these cases, if they are medications that are prescribed to the decedent, is to list the confirmed medical history for which the medications are prescribed. In this last example, you might list a clinical history of anxiety and seizures like I've done here. This information can be obtained from medical records or treating physicians, and state prescription drug monitoring programs or PDMPs can help to track those sources down. In addition to only listing the substance with a direct role in the death and excluding those that are inconsequential, it's also important to try to list the actual substances or substance that the decedent used, and not byproducts or metabolites. Much as I mentioned in the last example, you would not list the benzoyl as it's a byproduct of cocaine. One common example of this is related to heroin deaths, where you have to actually interpret the toxicology report to most accurately complete the death certificate. Heroin doesn't generally show up on a toxicology report listed as heroin. It shows up as a fairly high level of morphine and a much smaller ratio of codeine. This ratio, especially when coupled with either confirmed heroin found at the scene, history strongly supporting heroin use, like reported history from the family or friends, or a toxicology finding of 6-monoacetomorphine or 6-MAM, would indicate that this morphine and codeine combination is actually heroin. So in this case, it's not an overdose on morphine and codeine, it's an overdose on heroin. In these cases, the parent substance can be identified and the cause of death should be attributed to heroin toxicity on the death certificate. In all instances, the drugs that are identified as the person actually having consumed and overdosed on, be that directly listed on the toxicology report or able to be inferred, such as with heroin, these should be specifically listed in the cause of death statement. Statements like drug overdose or multiple drug toxicity, or even a category of drugs like benzodiazepine or opiates, do not paint a clear enough picture of what happened and don't provide all the known information and don't really comprehensively fulfill our public health responsibilities. With all that said, I will talk briefly about delayed overdose deaths because these can present special challenges. All the same principles should apply on overdose deaths, and ideally, even when someone dies in the hospital, their admission blood sample is obtained and toxicology is performed, and you get the specific toxicology findings and cause of death and follow these same principles. However, it's almost never that easy. So often there are cases that are significantly delayed and blood samples from admission have been thrown away, so there's nothing left to test for toxicology. In those cases, you just have to do the best you can with what you have to be specific as possible. I've had to sign these out as a category of drugs, intoxication on a category of drugs such as benzodiazepine toxicity, because that is all the hospital toxicology screen could tell me. And a week later, there were no samples left to collect from the hospital, and the forensic pathologist had nothing else to look at but the hospital toxicology screens. It's not optimal, but it is the reality of what we do and what we have to work with at times. Just some ways to try to work around this include making sure you check with the blood bank at the hospital, as often the blood bank keeps samples longer than the regular lab. Develop protocols with your local hospitals where maybe they'll keep samples for some additional time. And ensure that you have developed good working relationships with the hospitals in your area so that they do report these cases to your office in a timely manner and maybe before the evidence is discarded. You're probably thinking, but Kelly, my toxicology report on my decedent came back with 8 substances, all are respiratory or CNS depressants, and we think they all had a synergistic effect. Are you saying I have to list all of those on the death certificate? Well, we certainly are seeing more and more cases with multiple drugs in the system. Long gone are the days of just 1 or 2 findings. And this can pose a challenge, especially because the death certificate only has so much real estate. So you have a couple of options. You can use multiple lines on the death certificate and list them all out. When you do this, as you can see in the example, the key is to ensure that line A ends with a comma and then the word and the next line starts directly with the name of the substance. So you can see here line A ends, so fentanyl, comma, and line B starts with lorazepam. Or this is where you can say multiple drug toxicity and include and list some of the most significant findings. So in this case, therapeutic levels of diazepam, lorazepam, and others may have had an increased effect on respiratory depression and might be part of the cause of death, but the fentanyl, alprazolam, and oxycodone in fatal levels probably had the greatest effect. So you don't want to necessarily rule out the others, but you don't want to have to list everything. In this case, an acceptable solution would be to list the cause of death on line A as multiple drug toxicity to include alprazolam, fentanyl, and oxycodone. Again, keeping them in alphabetical order. But rather than listing them all out, you're saying include, which indicates that there are others. So be as specific as possible, or at least as much as possible, and be distinct in your cause of death statements. Don't just say polypharmacy or multiple drugs. But if you really can't list them all, use the phrasing to include so it's obvious that this isn't a comprehensive list. I've talked a lot about overdose deaths where the cause of death is related to drug toxicity, but what about drug-related deaths that aren't necessarily an overdose death? For this, I'm going to talk about sort of 2 different categories. The first is a death related to the effects of drugs, such as a stimulant like cocaine or methamphetamine leading to a stroke or acute cardiac event. A stimulant can cause a hypertensive crisis that can lead to a fatal series of events. This is an example of a situation where getting the death certificate correct really starts with the initial phone call. If a hospital reports the death of a 40-year-old male with a stroke confirmed by head CT, that might seem like a natural death. That is until you query the history further, only to learn the decedent has a history of substance use or maybe even a positive drug screen in the hospital. Suddenly, the underlying causal sequence to that stroke makes it a fall, with the jurisdiction now being of the coroner medical examiner because it might be a drug-related death. Let's say your office does a complete investigation and ultimately the forensic pathologist decides the cause of death is a stroke due to acute methamphetamine intoxication. Well, you should now be thinking, how can I be specific and distinct in my cause of death statement? It is still a death related to an acute intoxication and the manner is accident, and the injury information would reflect an injury, perhaps related to his smoking or inhalation of methamphetamine, maybe even listing on the death certificate that a pipe was found at scene. So the second example is a bit different than what we have been talking about, and that is a death related not to acute intoxication, but rather chronic intoxication. These are generally natural deaths, but I did want to mention them since they are sort of drug and or alcohol related. They're just not acute drug related. These would be cases where there's significant pathology found at autopsy that are complications of long-term drug or alcohol abuse, but then toxicology comes back negative or maybe with just low levels of alcohol. In this situation, the pathologist should specify the most important specific findings, such as gastrointestinal bleeding. That would be due to esophageal varices due to chronic alcohol use, and the noted pancreatitis is listed on part 2. This would be the exception to using terms like use or abuse, and this would be classified as a natural death. In this case, you can use the terms use or abuse because it's not an acute event. In this example, you can see the time intervals are completed and contribute to the causal sequence. The GI bleeding was for hours, perhaps due to the consequence of esophageal varices for days, which was in turn due to years of chronic alcohol abuse. And it's a chronic death, and it's a natural death. In some jurisdictions, these natural complications may be so well documented and acute toxicology rolled out that the primary care or attending physician may be permitted to sign the death certificate in these cases. One common example of this sort of known complication of chronic use might be a death in a hospital inpatient setting with a condition related to skin abscesses from skin popping from prior injection of drugs. The cause of death on a case like this might be determined to be endocarditis due to multiple infected skin abscesses due to chronic intravenous drug abuse with the manner of natural. Again, it's okay to use the term abuse or use as you're not describing an acute event like an intoxication death. So on these cases, always ask yourself, but what does it due to? If there isn't chronic history to explain the findings, ask yourself if complications of intoxication could be involved. Manner of death is one of the remaining fields on the death certificate that still needs to be completed. The options are natural, accident, homicide, suicide, and undetermined. There's a lot of variety in how offices view this, especially as related to overdose deaths. I personally love the name guidelines about manner of death. These have been well vetted and are widely accepted, and to me, they just make a lot of sense. They're good for a lot more than just overdose cases, so I encourage you to familiarize yourself with them if you haven't. Again, it's very important to be consistent, but it's always okay to change your course to a new consistency as society changes. And overdose deaths are definitely something society has changed on. Unless there's a preponderance of evidence to suggest otherwise, overdose deaths are generally considered accidents. An example of preponderance of evidence to support a different manner would be a suicide note, suicide history or ideations, as well as consumption of 2 full brand new bottles of pills along with a bag over the head. Okay, it's certainly rare that there's that much, but a couple of these can suffice as evidence of suicide. And as the neutral independent recorder of death, we would need to list the death as that on the final death certificate as a suicide. Just as there's still a stigma in society with overdose, there can be the same stigma with suicide. And it unfortunately can be upsetting to the family, but we all have to be truthful when it comes to completing these death certificates. And the family needs to understand that we have to play an independent role in this process. But unless there's a preponderance of evidence to suggest otherwise, it's generally okay to default to accident. I also want to cover homicide as a manner of death related to overdose cases. Lately, we are seeing more and more prosecutions related to overdose because someone gets what they think is heroin or cocaine, and it's actually laced with fentanyl. A few offices have been tempted to call these cases homicides because they got tainted drugs. But given there's no regulation on cocaine, there's no regulation on heroin, and no guarantee of what you're getting or strength of what you are given, this would not make the case rise to the level of homicide from a medical legal death investigation perspective. They usually lack the volition that is necessary to rise to the level of homicide. Certainly, the law enforcement entity and local prosecutor are welcome to pursue manslaughter or even homicide charges from their legal perspective, but the manner we are determining is different. Just as in a motor vehicle crash with a drunk driver, where the death should be certified as an accident, these cases would be as well. I've also heard accusations from families that maybe her boyfriend gave her the drugs. Well, the case may well be that he injected her, but unless he did so against her free will, that too would not be a homicide. If there are legitimate indications that he held her down and forcibly injected drugs against her will, then yes, that would be a homicide. But those cases are rare. So again, the majority of overdose deaths are generally an accident. Now that leaves us to discuss undetermined. Undetermined does have a role in a small percentage of drug-related deaths, but should just make up a small fraction of the total cases. This should be reserved for the tryingest of cases, those where either you just don't have enough investigation to have a preponderance of evidence towards suicide, but at the same time, you really just can't rule it out. Many people with a substance abuse problem have a tendency to not care if their drug use kills them and are what I always sort of describe as passively suicidal, not caring if they die, but the need to use is just so strong. Unless they are actively suicidal and actively wanting to die, though, there's a big difference between not caring if your habit kills you and wanting to die. And these do fall into the accident category, barring indicators of actively wanting to die rather than just not caring if your addiction ultimately kills you. Remember when I said that a death certificate is a legal record of death? Well, it is important that the death get recorded and that record submitted in a timely manner. But as is often the case in drug-related deaths, we won't have any answers about the cause of death for weeks or more likely months until all testing is back and we've had a chance to review all the reports, consult with our forensic pathologist and forensic toxicologists, and wrap up any additional investigation like checking the PDMP and talking to the primary care physician. In many jurisdictions, you're lucky if it's 90 days later and you finally have an answer. In order to assure that the death gets registered, even without a known reason, it's important to complete a death certificate with the cause of death listed as pending investigation or deferred or other similar language, and select the manner of pending investigation on the death certificate, and do this all as near to the death as practical. And then 90 or more days later, when you do finally have a cause of death, you can file an amendment at that time with the now established cause of death, the injury information, and final manner. But do go ahead and make sure you file those pending or deferred death certificates with the registrar in the meantime. And then get the amendment done in as timely of a fashion as you can, understanding that sometimes you have to do test after test until you figure it all out, and it can take a long time in certain cases. So we're on the home stretch now. There's one last section of the death certificate that needs to be completed, and it's a pretty important one, and that's the injury information. First, you have the date and time of the incident. This should be pretty straightforward to approximate as best you can as to when you think the decedent actually used the substances that are in their system. Some of these uses are over the course of a night or multiple hours, so do your best to approximate when you think it was. If you truly have no idea and cannot make an educated guess, you can usually list unknown in most jurisdictions. But that isn't helpful for public health purposes, but sometimes it's the only clear choice. Equally straightforward is, hopefully, the location of injury. Again, use the best information that you have to get as close as possible to accurate. This includes the address of the location, as well as the type of location, be it a park, a sober living facility, the decedent's residence. In this case, it's listed as a motel. That takes us to the last field, which is how injury occurred. And this is probably where there's the most variance throughout the country and even within jurisdictions, and the most opportunity for positive improvement. I'm going to tell you what is optimal, and hopefully you can try to figure this out for all the decedents you're certifying deaths on. But I understand that more times than not, it might not be feasible to have all of this. So do your best to get as much as you can. What you ideally want to include here is as much information as you reasonably can about method of administration, be it via injection or inhalation or ingestion, or any of the other options. Then ideally you want to include where the substance was obtained, whether it was illicit versus prescription or diverted, and then any other information that seems pertinent that you might want to include. So in this case, it might read ingestion of prescribed hydrocodone with diverted alprazolam. You can always use the word probable too. You may not know for sure that they took the heroin fentanyl combination intravenously, but strongly suspect that's the case. So probable intravenous injection of heroin and fentanyl would work. In this case, I did not specify illicit along with the heroin since there really isn't another form. For a death including alprazolam, you would want to try to clarify that it was ingestion of illicit alprazolam and that they are also believed to have smoked methamphetamine. If you do happen to know the condition for which a medication was prescribed, you can include that as well. For this example, ingestion of diazepam prescribed for anxiety, along with ingestion of unprescribed oxycodone is listed. I'm assuming you know it's not prescribed to them based on what you found in the PDMP, but you don't know where they got it, whether they diverted it or obtained it illegally off the street. Feel free to include more. Feel free to state that a syringe and black tar substance were found nearby. You will notice for all of these, the manner is accident, even though in the first case, the decedent reportedly thought he was buying heroin, but it ended up that it was laced with fentanyl. The key, again, to provide as much information as possible so those reading the death certificate can have a good indicator of exactly what happened. Much of this can be obtained at the scene and or during your regular interviews, so go ahead and try to get it. I know everyone is busy and likely does not have time to track down 42 extra informants to find all this out, but the aim is to get as much as you can in the interviews that you do conduct. As with cause of death, the key is to be as specific as possible and to provide as many details as possible. In case you want to know more, CDC has a reference guide on this topic and generally suggests including even more that I have suggested here. So the first step to solving any problem is to understand that problem. Just like it's much easier to solve a puzzle if you know what it's supposed to look like. If the medical examiner and coroner community as a whole doesn't share the vast amount of information that they have with the correct people to let them know what the overdose puzzle looks like, then it's hard for those people to do something about the problem. If they don't understand it, it's hard for them to do something about it. If a death certificate is filed stating the cause of death is an overdose with no other details, is this something that should be counted as a statistic towards the opioid epidemic or not? We just don't know. And until those in public health know the true extent of the problem, they don't know how to go about solving it. So let's try to help them out. Let's try to provide them with a lot of information. Let's try to provide them with a lot of consistent information, consistent between different jurisdictions. Again, my goal was always to put myself out of a job, or at least to have a job slow down to the levels that we enjoyed in the early 2000s. A week of not having to go from overdose to overdose, and notify family after family that their child has died or dad has died. I just think that would be so wonderful. So one way we can contribute to that is by providing a lot of information on the death certificate in the best way possible. I wanted to share a couple of my favorite resources on this topic with you as we wrap up, many of which I referenced throughout my presentation. The first is the CDC guide on death certificates on drug-related deaths, the name guidelines for manner of deaths. There's recommendations on drug-related death investigations put out by OSAC, and then NAME's position paper on opioid-related deaths. And then lastly, there's a free training put together by NAME and RTI and opioid-related death investigations. To all the last responders and forensic practitioners who have stuck in there and are still with me, thank you for your attention. And I hope you can maybe make a small change in how you do things in your office to help serve the public health role that our profession has so much to give to and help understanding of drug-related deaths. To aspiring forensic practitioners, I look forward to working with you one day. And to interested parties, I hope that you've learned something about death investigation in this country and some of the many challenges this amazing community faces. Stay safe and stay sane. And I believe I have a few minutes for questions.
All right. Thank you, Kelly, for that fantastic and informative presentation. Let's go ahead and get right into some questions from the audience. First one I have here, can you talk about positional asphyxia as related to drugs?
Yeah, thanks so much. That's a good question. There's been some research done on that recently. And, it is certainly something that we're seeing. A lot of these decedents are found bent over, where positional asphyxia does become an issue, or they nod off into a position that compromises their abilities to breathe. And it's been identified as an issue. So that's a great thing to include on the death certificate if that is something that you're suspecting, something that the forensic pathologist is suspecting. So you could list that on line A, positional asphyxia, and then the underlying line B would be due to the whatever the drugs are in their system as normal. So rather than just acute cocaine intoxication or acute heroin intoxication, it'd be optimal to list positional asphyxia due to acute heroin intoxication. And then you could also include that information on the injury information, the injury section. You could include compromised position, wedged between bed and dresser, while intoxicated, or after ingestion of heroin or injection of heroin or something along those lines. So that's a great question. And those are the kind of things that is optimal to include on the death certificate. The more information you can include on the death certificate, the more information that public health can take and try and educate the population, so that if positional asphyxia is identified, they can maybe or suggest to folks that are using drugs that they might not want to use alone, or they might want to have a sober buddy to not only help to administer their naloxone, but also to ensure that they don't get into a position that compromises their breathing. Great question.
Awesome. In that same kind of line about how much information to put in the death certificate, I have another question here. What if drugs are detected in the system but in low levels and not the test? Should they still be mentioned on the death certificate?
So there's two schools of thought on that. And there are definitely two schools of thought. The way that my office, we always did it, our pathologists always wanted, was to include that information, just so that it captures that there were drugs related to the death, that maybe it's a natural death, or a traffic related death or something like that, where it's a finding, and it's still an important finding, the fact that the person was on drugs. So in my office, we did always include that. Our pathologists always wanted to include that information as part of the cause on line B or on part 2. But there is some concern that if that information is on there, sometimes they do get coded to reflect that information, whether it's the pathologist's intention or not. So that's a place where maintaining consistency is really important. And as long as you do it within your office consistently, I think that's the most important one.
Perfect. Thank you. So I got a question here about the question asker is saying, my pathologist doesn't feel comfortable picking which drugs to list and which to leave off. So what do you suggest that they do?
That's a good question. They can list anything that has a contributory effect to one another is generally the best option. So it's something like THC, along with respiratory depressants. The THC generally doesn't have an effect on the death the way the other drugs do. So that's really going to be up to them to decide which ones they think are the most important. Something that's in a really low level or a subtherapeutic level might not be as relevant as the things that are in higher levels or illicit drugs, perhaps something that there is not a prescription that they've been on for quite some time. So that's really going to be up to the doctor to determine what they think the effects are that cause the death.
Gotcha. Next question here. How are survival periods addressed in regards to death certificates?
I'm going to assume that this means, somebody who takes the drugs and then dies a couple days later or even a couple hours later. So there's, I did talk about drug-related deaths in hospitals. And so that would be, the easiest way would be to list line A would maybe be the diseases or the conditions that develop on the hospital. So you might have something like pneumonia, because perhaps they're on a ventilator in the hospital for 2 or 3 days. So it might be pneumonia due to heroin intoxication on line B. And so then you would also use the time intervals. And I said that those are mandatory in a lot of states and becoming more and more used in different states. So in the section that has the time intervals, that's how you can capture that information. So for example, in the case where you had pneumonia, that might be hours, or pneumonia while on a ventilator for hours, and then acute heroin intoxication could be days, and that would indicate that they were on a ventilator and developed pneumonia over the course of several hours, perhaps due to the heroin that was taken several days prior. So that would be captured in the time intervals. And then also along the injury information, you do include the date and time that you believe that the person initially used the substance. So the date of death might be the 15th of the month, and the date of injury might be the 10th of the month. And so that's how you would know that it was a delayed incident. And I hope that addresses the question.
Actually, I've got another question here, kind of ties back to what you mentioned with the delayed deaths in hospital. And they're asking, are you saying that an autopsy is necessary on those delayed deaths in hospitals?
Not necessarily. If you have good toxicology, certainly not. And we didn't usually autopsy those cases if they were, delayed, where there was no longer likely to be a drug still in the system. We usually would have our pathologists review the medical records on those cases and would sign those cases out based on the review of the medical records, unless we could get the blood samples from the admission, in which case we would still want to do toxicology. And in our office, we didn't do toxicology without also doing an autopsy. And that was a decision our pathologist made, that if they were going to be truly determine the cause of death based on their testing, that they wanted to go ahead and do an autopsy to have the true context for that toxicology. So certainly in those cases, you would want to do the toxicology. If you have those admission blood samples, you'd want to do the toxicology to get the levels and the more specific testing than the hospital drug testing. But as far as whether your comfort level or your pathologist's comfort level is to do an autopsy along with that toxicology, certainly best practice would always be to do an autopsy, but that's just not necessarily feasible in all cases. And I don't think is at all unreasonable to just do the advanced toxicology in those cases when you have, volumes and volumes of hospital records to refer to.
Sure. Yeah, it sounds overall everything is very situational, both with the case and who the medical examiner or coroner is, the pathologist is, all that kind of stuff. It's sounds like there's a lot that influences how to make the best case decision.
Yeah, and we have to take into account resources. I mean, we have such a limited supply of forensic pathologists in this country that their time and expertise is limited if they try to stay within the caseloads to maintain accreditation. These are all factors that play into deciding whether autopsies are going to be done or not. Again, best practice is one thing, but reasonable practice and just what's reasonable is not always best practice given our situation in this country and given how increased these overdose cases are these days.
Sure. Well, I think we have time for definitely one, maybe two more questions. So just putting that out there in the audience. If you have any final questions for Kelly, please send them into the chat. We'll get those answered before we wrap things up. While we're waiting and seeing if anybody else has anything else and kind of talking about resources in general to segue into it, here are those same URLs, those links that Kelly put in her presentation. I have them up here again. And just to make note, I know it's very difficult to sit here and try and either write down or type in all these URLs with their numbers and letters. So we have actual button links on the main page of this webinar's registration page. If the page that you were at before you came in to actually view that main page, you'll see on the left underneath Kelly's bio and to the left of the webinar's summary. So feel free to use those links. That'll get you in the same spot that all these URLs are there. But other than that, Kelly, do you have anything else that you wanted to mention or just kind of sign off on before we would just do one final couple seconds here for another question and see if you have anything else that you wanted to mention?
No, and thanks for making sure that these links so they were a place that were easily accessible. And I really, a lot of what I presented definitely is best practices. And I think, that's always the goal, is to aim for best practices, but we have to all adapt those practices to the resources that we have in our jurisdiction. And given, the ever increasing number of overdose deaths that we've been seeing, especially within the last year, I think we're all doing an amazing job, but I think just trying to capture how we do that job onto the death certificate to share that information is what's really important, and to understand the role of that death certificate and how that information is used, to keep doing the investigations we're doing and determining the causes of death that we're doing, but how it's reflected on the death certificate is, I think, hopefully the main takeaway.
Awesome. Well, Kelly, again, thank you for taking the time and providing your expertise and your background knowledge and all of that for putting this presentation together and answering these questions. We really do appreciate it. I think I know based off of the comments that we're getting in the audience chat we have, it's very well received. You did a great job, and we really appreciate you again coming here and providing this information.
Thanks, Tom. Thanks everyone for listening in.
Before you leave today's webinar, we ask if you could participate in a short 5-minute survey. You will see a checkbox icon directly above the chat. Simply click that button to be linked to the audience feedback survey for today's event. Your feedback about our webinars is critical information that helps us improve and continue to provide you the best webinar experience possible. If you could please take those few moments to complete the survey, we would greatly appreciate it. Lastly, across the top of the live stream window are links to all our social media profiles, including Twitter, LinkedIn, and Facebook, a link to our website at forensiccoe.org, and a link to listen to episodes of the FTCOE's podcast, Just Science. There's also a link to sign up for the FTCOE newsletter so you can stay up to date with everything that FTCOE is doing in support of the forensic community. Thank you again for attending, and we hope everyone has a great day.